We are now recording.
All right. Good afternoon, guys. I'm tasked to do ABGs for you guys. Now, credentials, I'm a pulmonologist, I'm an intensivist, but I'm not going to bore you with blood gases. And I'm not going to let you memorize all these formulas because these are things you can Google. Which means I also did not memorize them because I plugged them up and Googled them. What's more important is one, you recognize what's important, and two, how do you go about it? So let's start with this sheet over here. The first question is really, how do you get the blood gases? RT gets it, right? ABGs. Now, we just don't order it for the sake of ordering it. And that's why there's a lot of components to the blood gases. Basics is how do you get it? And how do you know if it's really an arterial blood gas or not? So first of all, safety is the most important, okay? And somebody is on Eliquis, some Plavix or whatnot, you got to be more careful. So what is the test that you need to do before you can get a blood gas? I'm sorry? No. To be able to get it from the radial artery. There's a test, it's called Allen's test. Okay, you get a Kit Kat. So Allen's test is basically trying to see if there's collateral circulation. What that means is you're going to make the patient make a fist, and you basically compress the ulnar and the radial artery really firm. You let the patient open it, and if it's pale, that means there's not much circulation in there. And if you release the ulnar side, you should see the hand kind of become better color. What that means is that the circulation in the ulnar artery is intact, so you can poke the radial artery. What happens if you poke and there's no collateral circulation? You might lose that hand. That's one of the reasons we don't do ABGs or arterial lines in brachial arteries, because the brachial artery is one singular artery, it doesn't have any collaterals. So we try to avoid that. But if you don't have a choice, you're better off having a patient who doesn't have one hand than a patient who's dead. So, but that's the safety of it. So ABG is the first one. That's the, how do you get it? Anybody who knows why, who orders it, why do they get it? I mean, there's a bunch of you bedside. Who orders it? Dr. Cook orders it? Or Dr. Arnold, why does he order it? Oxygen? Oxygen. So let's start with oxygen, one topic at a time, because there's a lot to uncover here. So the question now is oxygen. You just had your lesson from Amy earlier about hemodynamics, right? You guys were listening, right? So what's the formula for cardiac output? So cardiac output is equals to heart rate times stroke volume. Good. But why is cardiac output so important? What is the heart meant to do? It's meant to pump blood. And what is that blood carrying? It's carrying oxygen, which means the cardiac output is just part of one big formula. And I'm not going to bore you with that. I just want you to understand that it's there. It's called oxygen delivery. Okay? Oxygen delivery, so O2 delivery, is basically cardiac output times the oxygen content of the blood. Okay? So the question now is, you have a patient who's crashing. Oxygen content. Okay? You have a patient who's crashing. The pulse oximeter is reading 80%. Somebody orders a blood gas. Well, the RT is doing an albuterol nebulization somewhere. You can't order it. It says 80 on your SpO2. Are you going to wait, or are you going to believe the SpO2? What is the best answer to that? Correct. And you look at the patient. Patient looks great. SpO2 is 80. You increase the oxygen and you wait for the RT. Patient looks horrible. I don't care if that SpO2 is 95. You have to call somebody, you call for help. Okay, that is the first lesson here. Is these blood gases, they don't mean anything. What your patient looks like means everything. So the first lesson here is we get the blood gases. You have the copy over here, and somebody's saturating at 80. What number are you first going to look at in your paper?
Yeah.
Which one?
PO2.
PO2? She's the only one answering. So I get you get another Kit Kat. But PO2, that's right and somewhat sketchy. Why is that? Why am I saying that PO2 is somewhat sketchy to look at? Remember oxygen content in the blood? Where is the oxygen in the blood? The oxygen in the blood is where? Where does it sit all the time? In the hemoglobin. So oxygen content is actually in the hemoglobin and where? There's something in plasma. So it's dissolved in the hemoglobin and it's dissolved in the plasma. Guess where your PaO2 is? It's in the plasma. And where is your pulse oximeter sitting? It's the one in the hemoglobin. Which one is more important between the two? It's the one in the hemoglobin, right? So this one is a surrogate. It's important, especially if your pulse oximeter is not reading well. But it's also the minor part that doesn't participate in gas exchange. Why? What's the formula? Well, the formula, and I'm not going to bore you with the formula, it's SpO2 times 1.34 times hemoglobin times SpO2 plus PaO2 times 0.003. You see that AO2 there? It's less than 1% of the whole oxygen in your blood. It's important because if you can't get this reading in there, then you have something in there. What's a lesson here? The lesson here is you always look at the patient and you look at your waveforms. Your waveforms doesn't look good, get a blood gas. If your PaO2 looks okay, what do you mean by okay? It's always a plus 30, give or take. So if you have a 60 of PaO2, give or take, that's a 90 on the SpO2. It's a very poor marker, but something nonetheless. Look at the bottom numbers in there, derived. Do you see the derived or the co-oximetry? If you don't do the co-oximetry, that SaSO2, that's the most important number. If you did a co-oximetry, that SO2 is actually the SpO2. So you get a blood gas, you get an SO2. The first number that I look at is not the PaO2. The first number I look at, if I'm only concerned about the oxygen, is that SO2. You see it? Okay, so that's the first one. Now, you have the oxygen. The question now is, how does oxygen exchange happen? And this is still related to your blood gases, because blood gases is not just, oh, it's acidosis. This is something I'll discuss later, but I think it's minor, but everybody has to understand why I order a blood gas, why intensivists do it. And a lot of it has to do with have you ever heard of an AA gradient? So it's an alveolar arterial gradient, AA gradient. Okay, that is part of delivering oxygen from the lungs to the blood. Okay, you can Google AA gradient, big A and small a. When somebody is low on oxygen, we as pulmonologists or even medical students or residents are trained to check the blood gas to compute the AA gradient. This is the oxygen in the alveoli. and this is the oxygen in the artery. A normal number is 5 to 10, and that means that oxygen is diffusing very well from the lungs to the blood. If that AA gradient is impaired, that means that oxygen is not diffusing well. There's something wrong in your system. Can you follow? So somebody has pneumonia, that alveolar, that A minus A is going to be impaired. Then you have something wrong in the system. If you have somebody who has pulmonary embolism, which you see all the time, that A is going to be impaired. Something's blocking it. So everything revolves around the causes of oxygen, which leads us back to that arterial formula. It goes back to the oxygen content. The question now is, somebody short of breath, they lose a lot of blood, and they're very short of breath. What is the problem? Is it oxygen? Do you intubate the patient? No, you transfuse blood, because that hemoglobin matters a lot in that formula. Does that make sense? So the train that's carrying your oxygen is what matters the most. So I can't express this enough. Now, trick question. Your AA gradient is normal, but your oxygen is still low. You do a blood gas, and your SO2 is 80. So it's a true low oxygen reading. But your AA gradient is normal. What is the problem? So AA gradient, remember, this is alveolar and arterial, which means this is purely a lung problem. What can give you a low oxygen that's not a lung problem? You're gonna have a heart problem. What's the most common? People get tubed all the time in the ER. Oh, this patient is not awake enough. They have low oxygen. AA gradient is normal. It's because they don't breathe enough. Hypoventilation. You're hypoventilating, and you have a normal AA gradient because your lungs are fine, but the patient's not taking a breath, which means this is very helpful for patients who are actually deteriorating. Very good clinical scenario. Dr. Smith operates and does a carotid. Post-operatively, they go to the cardiothoracic ICU, CVU, and your patient's low on oxygen. You do an X-ray, clear X-ray, but the oxygen is low. You do a blood gas, and the blood gas is normal. And the AA gradient is normal, because you can get it from the alveolar arterial gradient. Let's say it's normal. That means there's nothing wrong with the lungs, correct?
Yes.
Which means it's your sedation.
Yes.
It's the post-op sedation. Well, what if it's abnormal and your chest X-ray is clear? What is a lung problem in post-operative patients with a clear chest X-ray?
Which is the green.
Well, no, your AA gradient is abnormal. That means there's something wrong with the lungs. Good, atelectasis, but it's chest X-ray would show up with the atelectasis. What's a very common problem in post-op patients, especially hip surgery patients? Pulmonary embolism. So you do a blood gas, your AA gradient is normal, then you know you just got to slap that face and, hey, wake up. But if they're abnormal, you say, hey, Dandan, come over here. We need a CTPE because this might be a PE. Correct. Does that make sense now? Now, the other formula is so you have the arterial oxygen content. You can also have the alveolar oxygen content. What is the formula for alveolar oxygen content? That's why I wrote it there. So this is also very useful. So oxygen in the alveoli. So this is in the lungs itself. And the formula is FiO2 times, what is that? FiO2 atmospheric pressure minus pressure water times PaCO2 over 0.8. Now, I'm not gonna let you memorize that formula. It's bogus. But I want you to understand what that formula contains. It contains what? The FiO2, which is most cases, it's 21% oxygen. How about that one? PA atmospheric pressure, it's 760 minus 43. Now, that's just something I memorized because I use this all the time. But this is the reason why you're low, your oxygen, not your oxygen, why people are struggling to breathe in high altitude. It has nothing to do with the amount of oxygen in the air. It has a lot to do that this number over here is lower. And if that number is lower, that entire oxygen is going to be lower. But this one is always 21%. But the content in that alveoli is going to be much lower because that's part of the formula. Does that make sense now? Now, you see this one, it's a subtraction sign, minus PaCO2. What happens if you're hypoventilating? It's going to go up. What happens if it goes up? It's a subtraction sign. It occupies the same space as the alveoli. So people who are having problems with ventilation, if it goes bad enough, they're going to go hypoxic on you. So let's say a PCO2 of 40, it becomes 80 or 90, they're going to go hypoxic on you. That's because that formula is right there. So two formulas, all the components are there. What's important? Hemoglobin, FiO2. This one we're never going to use unless we're in the boondocks. But PCO2, hypoventilation. Okay, so that is the problems with oxygenation. I know it's a lot to take, but all you got to remember is that hemoglobin is just as important as that pulse oximeter. Your hemoglobin is low, that whole content is going to be messed up.
That'd be a really dumb question.
Yes.
Where's FiO2?
FiO2 is how much you give it. So you how much you give, which leads us to the second part of the discussion. How do you give oxygen? How do you give the oxygen? Let's say somebody is low on oxygen. What's the first one? Nasal cannula. Okay, you get a Kit Kat. Well, no, yeah, Kit Kat. You're breathing nasal cannula. How much can you give in the nasal cannula?
Low.
So the next part is doing high flow, right? What's the difference between a nasal cannula and a high flow nasal cannula?
It's the 6-150.
Correct. Why does it go to 6? 6. Will it electrocute me if I went into 7?
I won't give them any more.
Now, the reason for that is simple. When you go above 6, that air is not humidified anymore. And it causes that nose to be extremely, extremely dry. And not only is it 6 liters, it's going to leak in the mouth because of the pressure. So 6, in terms of a poor man's language, for every liter that you give in the nasal cannula, it will give you +3, +4%. So you got a 21% on oxygen, you have +3. So your 1 liter is actually 24%. Another liter is 28%. Then you go to the high flow because it's more humidified. What is the next step? Either airbo or a non-rebreather. What's the difference between airbo and a non-rebreather?
Yeah, low rate and then FiO2 airbo.
Correct. Yes, so you have a flow rate which gives you a little bit of a push, almost like a BiPAP, whereas the non-rebreather, you're purely relying on the patient's effort on trying to take a breath. So if you have somebody who probably needs a little push, we go BiPAP or we go airbo. If that somebody has a pure oxygen issue and can take that breath, you go non-rebreather. But which one can give you more oxygen?
It's the non-rebreather actually.
They're both not completely accurate, but the non-rebreather will give you more oxygen. Either or, the next step is BiPAP. Okay, BiPAP you have two numbers in there. And I don't know if I should discuss this because I'm only dealing with blood gases. Should I- Keep going, keep going. My overall objective is really just for you not to look like idiots to when you look at the numbers and like, the heck is this? I don't know.
More than an hour for that for me.
But that's what I'm trying to point out is I just want you to know what the numbers mean. I would just want you to know what the numbers mean, okay? So the BiPAP has two numbers in it. Two numbers. There's a higher number and there's a lower number. EPAP and IPAP. Can you follow me? Everybody seen a BiPAP? What's the third number? Third number is the FiO2. Simple enough, right? So there's three numbers on the BiPAP. So we use this for sleep apnea patients. We use it for COPD patients. But if you slap it on their face, there's a pressure that pushes in. It's called inspiratory pressure. And it follows. You get that breath. That's the higher number. And there's the EPAP, which is the lower number. So after you give that breath, it won't let you close the alveoli because you inhale. And then when you exhale, it won't let you collapse it. That's called the EPAP. EPAP is almost similar to the term CPAP. It's almost similar to the word PEEP. They're just used in different instances. But EPAP is almost synonymous to CPAP. It's almost synonymous to PEEP. Basically, it won't let you close your alveoli because if your alveoli are sticky, it won't open up. So when you inhale and you exhale, it won't let you completely close it. The remaining pressure inside that alveoli is called PEEP. And where does PEEP help? It helps with the oxygenation. Okay, so three numbers. I need to erase this one.
The next is.
I haven't. I'm gonna need more. Okay, yeah, we're gonna deal with blood gases. Just give me a second. So BiPAP, you got a higher number. IPAP, you got a lower number. EPAP, and you got the FiO2. Remember our formula for cardiac output? Heart rate times stroke volume. What is the formula for the lungs output? Anybody knows? It's called minute ventilation. Minute ventilation controls purely carbon dioxide. What's the formula? Respiratory rate times tidal volume. So they're just measuring almost the same thing, but different organs. Okay? Can you follow? So what controls your oxygenation? FiO2, which we already discussed earlier. And then PEEP, which is a little bit more advanced. I'm not going to discuss that, but it just leaves your alveoli open when you exhale, and it controls oxygen. Well, if your patient is awake, you cannot control respiratory rate. What you can control is tidal volume. And how do you give the tidal volume? Tidal volume is basically determined by IPAP minus EPAP. So the wider the difference between these two, the bigger your tidal volume. So if somebody has a problem with ventilation, it happens all the time on the floors. What number do you adjust? You adjust the IPAP and you leave the EPAP alone because you want to give more tidal volume. Clear as mud? Okay, now let's go to the real blood gases. Blood gases, okay? Now, when you look at an ABG, there's three important numbers in the ABG, just three. What's the first important number? pH, top of the line. What's the second important number? CO2, so it's the second. Oh, what's the third one? Bicarb. That's why it's a third. So 1, 2, 3, pH. Okay. So what is important with these numbers? Well, again, let's go back to scratch. Everybody kind of knows, have an idea what the metabolic disturbances are when you order blood gases, correct? I'm not going to narrate to you the whole spiel about metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. You just kind of need to know what the concepts are. There's two things in the body that controls these three. Two things. CO2 is the lungs, and this one is controlled by the kidneys. Okay? What that means is I had to watch simple nursing videos for you guys, and I got really good one. Really good one.
Down for you.
No. It's excellent for me because I like teaching. The lungs is basically your husband or boyfriend. You are the kidneys, and the pH is your marriage counselor or your kid, whoever you want as the arbiter. So there's a seesaw. The lungs controls the CO2. And what's CO2? CO2 is an acid. Okay? So CO2 is an acid. So if it accumulates in your system, when does it accumulate? We already gave an example earlier. Hypoventilation. I got Mamba candy here. It's my kids. But anyway, acidosis, you're not ventilating, respiratory acidosis, that lung is going to accumulate PCO2. The question now is the wife going to ignore that acid or not? If it chooses to ignore it, it becomes an uncompensated respiratory acidosis. I'm not going to let you memorize the formula, but there's one key thing you have to know. The pH is still the most important part of the equation. If you think somebody has respiratory acidosis because they were drugged or they had a stroke or for whatever reason they can't breathe enough, you have to first look at the pH. If the pH, what's a normal pH? Excellent. Who answered? Nobody wants to Kit Kat? Okay. So pH is 7.35 to 7.45. If your pH is normal, it would be safe to assume that that is their baseline PCO2 or bicarbonate. Be safe, not for everybody, but be safe to assume. So even if you saw a pH of 7.4 and your PCO2 is 100 or 90, that 90 is somewhere that they've been living at for a very long time. You need not panic. Does that make sense?
My carb's in like 40. Meanwhile, I've been smoking for 3 years.
Yes, correct. Well, what if your PCO2 is 60 and your pH is 7.24? Then you have a problem. Why? That means that is an acute problem, which means the wife did not have time to compensate for it. So it becomes a you problem. So what do we do for this? A poor man's way of trying to determine an acute change in the pH is for every 10 change or increase in the CO2, it would decrease your pH by 0.08. Okay? So if you have somebody with the pH of 7.24 and 60, what's your normal PCO2? 35 to 40? Ow, sorry. 35 to 40. So which means that changed by 20. That means that changed by 0.16. So you add the 0.16 and boom, that 7.24 is now 7.4, which means that person's PCO2 is 40 at baseline. Does that make sense? And what do you do with the BiPAP? When you see somebody like this, you increase the IPAP. You want to increase the difference between the IPAP and the EPAP because that's what determines your tidal volume. And tidal volume times respiratory rate is your output from the lungs, which is called minute ventilation. Okay? Fair enough? Next part. Respiratory alkalosis, which is the easier part. What happens with respiratory alkalosis? Can you give me an instance where people have panic attack would be number? You have too many.
No, don't give it to me. Give it to someone else.
Who else can give you respiratory alkalosis? What's a simple DKA? Yes, absolutely. You'll get a Nestle Crunch.
Thank you.
So DKA, why would you have respiratory alkalosis? Because you're trying to breathe. You're trying to breathe. Okay, what else? What's a typical admission for respiratory alkalosis? No, not stroke. Stroke is respiratory acidosis.
Heat. I said heat.
Asthma. Asthma exacerbation will give you respiratory alkalosis. So let's get that out of the way. Now, to the fun part, metabolic acidosis. Okay, so metabolic acidosis is controlled. Kidneys would be number one, but the key point is what instances can give you metabolic acidosis?
Sepsis, AKI, DKA, and big
So she basically mentioned everything: sepsis, AKI, DKA. Now, why would you have acidosis when you have sepsis? Loaded question. Because your problem is delivery to the tissue, and if the tissue is not getting their oxygen, they're gonna go into the lactic acid cycle, which in basic biochemistry, you're gonna generate more lactic acid. Okay? Trivia, what if you're a normal person and your lactic acid is up, assuming you're normal, what is the one thing you shouldn't do on your free time? Workout is okay because you're gonna clear it on your own, especially if you clear it. Alcohol. Why? Because the enzyme that clears alcohol is the same enzyme that clears lactic acid. NAD. Remember that NAD, NADH? It's on your pyruvate cycle and everything. So it's on that glycolysis, but you can look it up. It's because they share a common enzyme. So if you drink and your lactic acid is high, you can be screwed. Okay? I mean, you're screwed anyway. so that's what. So metabolic acidosis, compensation. I don't need you to memorize the formulas. It's all in Google. It's basically a seesaw. Okay, it's a seesaw. So if you have more acid, what is your body gonna do? More acid? Well, that wife is gonna throw bicarb. Okay? If you have less acid, so it's a seesaw. So you have a seesaw, and you have bicarb here, and you have CO2 here. And that's really all you need to remember. The rest are just formulas. If your acid is low, this bicarb becomes lower. And when are the instances it's low? You already mentioned it. You have kidney failure, you have sepsis. How about diarrhea? What is diarrhea going to do? You're going to poop the acid. You're going to poop the bicarb. So you poop the bicarb, it goes lower. So this is going to go like this. So what is the body going to do? When that acid goes up, it's going to decrease the CO2. And that is really the compensation. You just look at the seesaw. If your bicarb is lower, what is the CO2 going to do if your bicarb is lower? CO2 is going to be low. What is it going to do when your acid is higher? When your bicarb is higher. And when are the instances when it's higher? Metabolic alkalosis. We're going to metabolic alkalosis here. So remember what your stomach has? It has acid to digest. If you vomit the acid, what's going to happen to your body? It's going to go alkalotic because you're getting rid of the acid in the stomach. So what happens when that Bicarb, when that acid goes up, your bicarb is going to go up. So that's the compensation. What other instances can you have? Vomiting. In lieu of vomiting, what else can happen when you're vomiting? Well, when people vomit, what do you do in the ICU? You put an NG2. You know what do you put? Dr. Bissay likes that. Intermittent suction. So intermittent suction is not a harmless procedure. It can give you metabolic alkalosis. Why? Because it's suctioning all that acid. What else can happen when you suction all the acid in the stomach? Well, that flora of that stomach is going to change. When it changes, you're going to have problems with absorption. You're going to have problems with C. diff even. So you do it if it's important, but intermittent suction is really something that the surgeon has to order, but it's not without consequences. So let's summarize the alkalosis, still alkalosis. What do you do in a cardiac ICU that gives you alkalosis? It's on all your patients, tell you that. You're going to get a big prize if you figure this out. What is a medication in the cardiac ICU that you give on every patient that's going to cause you alkalosis? It's very easy. Not LI. Good answer though. You get a LR is an alkalinizing solution. What can give you alkalosis? That's the reason we switch from this drug to Diamox. And Lasix gives you Lasix. Who said that? You get a Bamba or Kit Kat. Oh, sorry. You don't want it?
Thanks.
Yeah. No. So Lasix. Why does Lasix give you alkalosis? That's a hard question. Why does it give you Lasix? What word is it? Dehydrate. Good. It dehydrates. You get a big prize. I get a maruchan. Let's look at it. Why
Lunch.
now, why does Lasix give you alkalosis? The answer is actually simple. I got a prize still. You want Maruchan? No, why does dehydration in general give you alkalosis? In popular terms, they call it contraction alkalosis. The reason is being you have a certain amount of bicarb in the body. And if you lose fluid, that bicarb remains the same. So relatively, your body has less fluid, but has relatively more bicarb. That's why it's by concentration, you have contraction alkalosis. But if you want to diurese more, cardiac ICU, what do? You give acetazolamide or Diamox. It's a diuretic that will get rid of it's a carbonic anhydrase inhibitor that will get rid of that bicarb in addition to getting rid of the fluid. Okay? So Lasix, alkalosis, very important. Bicarb, you give Diamox. Okay? So we have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Have we tackled everything? Okay. Let's do scenarios then. Somebody presents to you, 20-year-old, who presents to you with polysubstance abuse. Okay? But he's awake, he's panicking, and he's breathing a lot. And he tried to commit suicide. You do a blood gas, because he was also mildly hypoxic. Blood gases has a pH of 7.5 and a PCO2 of 20 and a bicarb of 24. What is the problem? Respiratory alkalosis. What is a drug? That's a hard question. What is a drug that gives you respiratory alkalosis if you took it as an overdose? What? It's over the counter.
Dandan.
No, not Tylenol.
Dandan.
Tylenol is gonna give you what? No, Tylenol is gonna give you what? Let's do Tylenol. Tylenol is gonna give you metabolic acidosis because your liver is in charge of the lactic acid. Your liver gets shot, your lactic acid goes up, then you have a metabolic acidosis. Aspirin. Aspirin toxicity is going to give you respiratory alkalosis. You gotta watch out for that. Okay? So respiratory, or that person might just be having an asthmatic attack. Remember, what is more important? You examine your patient. The blood gas, ABGs is only secondary. You're gonna see people say, I need a blood gas right now. That patient's turning blue. You don't need a blood gas. You intubate that patient. Okay? But you see this happen all the time. Where's the chest X-ray? Like, why are you out of the room? Your patient's crashing. You go into the room, you watch your patient like a hawk, screw the blood gases, screw the chest X-ray. You do what's in front of you, not something that you cannot control. Okay? Now, second question. Somebody from a nursing home, Mississippi Valley, comes to you and they are vomiting, they are dehydrated, they're hypotensive, they have a lot of infections in their sacrum. You do a blood gas, patient has multiple pressors, 2 pressors. But your ABG says a pH of 7.4. Why is that? Is it compensated? It was 24-hour thing. So compensation usually happens within 48 hours. Most patients cannot compensate within a few hours. 24 hours, not enough. 48 hours, they will. But 24 hours, 4 hours, no. So the question now is, does this patient have metabolic acidosis? Is it possible to have a normal pH with somebody in septic shock? It's a trick question. The answer is yes, because you can have even all 4 disturbances in one person and they just cancel each other out. And then the pH becomes normal. Why did I say vomiting? It's vomiting acid, right? It's vomiting acid. So it was metabolic alkalosis. There's also septic, lactic acid is going up. So that pH was going down, or was going up because you're vomiting the acid, and it turns out to be normal. So you look at the patient first. Okay? Now let's do a summary. See, I'm in time, 8 minutes. Let's do a summary. Question. Somebody is low on oxygen at bedside. What is the first number that you're going to look at first? Pulse oximeter. It's the one that you need to look at first. What are causes of low oxygen in the post-op situation? Hypoventilation, drugs. What else? PE. And what is PE versus hypoventilation in terms of your numbers? What is the difference? The AA gradient, you do an X-ray, it's clear, but it could be PE, but you do the AA gradient. How do you find the AA gradient? You go to Wikipedia, pull the numbers in. It's gonna show. Usually it's 5 to 10. It's 5 to 10, and there's usually a formula of something divided by age times 4. But the point is, it's abnormal. If it's abnormal, it could be PE in a normal chest X-ray. Okay. How about people with sepsis, lactic acidosis, right? Now, before we complete this, everything here, anion gap. That's another Pandora's box. We see this all the time. What does anion gap really mean? So you have, and I just really want to explain this to you. That way you know what we're following when somebody has DKA. Because the way it's going, all the ICU admissions right now are all DKAs. Anion gap is basically the anions and cations doesn't really have anything to do with acid base. It has and it doesn't. It's almost irrelevant because anions in general negatively charged ions can be acidic and they can be basic. Okay? Can you follow me? And same with cations, they can be acidic and basic. The reason we follow the anion gap is because when somebody's acidic, DKA, the pH is one parameter, but it's also painful for the patient to do an ABG. The pH is one parameter, the bicarb is one parameter. But the problem with it is the pH and the bicarb cannot see what's going on with the ketones. So there's a gap in your blood that causes it to be acidic, but you don't know how to monitor it. And that gap is called anion gap. Your pH is low, but the low bicarb cannot really account for it. Can you understand? We're trying to monitor somebody, but we're blind. They're acidic, but the pH reflects it, but I can't see it on my bicarb. And that's when the anion gap comes by. Causes of anion gap acidosis, there's a lot of them. DKA is one, and you go by the mud piles. Mud piles, anybody? You're gonna get everything here. Mud piles? Nobody?
No.
Nobody knows mud piles? Anion gap metabolic acidosis, what are the causes? Methanol, uremia, DKA, formaldehyde, isoniazid, lactic acid, ethanol, and salicylate. But that is the mnemonic. You don't have to memorize it. You just have to Google anion gap, metabolic acidosis, and I bet you the first image that would come out is mud packs. So here's the rest of my candies. That's the last of it. Do you have any questions? I know this is a lot, but
Can you explain the anion gap one?
so the
What
anion,
exactly is?
so anion gap, so the formula for it is sodium minus potassium plus bicarb. Okay? Sodium minus bicarb plus chloride. Plus chloride. Okay? There's a gap. So anion gap is this formula over here. Okay? Remember, when we have a metabolic acidosis, what we have discussed is most of it is affected by the seesaw. But there are acids in the body that the seesaw cannot control. We can monitor the bicarb all we want, we can monitor the pH all we want, but there are acids in the system that we cannot see, and it's causing an imbalance in the pH. Does that make sense now? So this seesaw does not only have a low bicarb, this CO2 will have the mud piles in it. Does that make sense?
Mhm.
The reason it's called an anion gap is because of the formula. But it's really almost like a misnomer because it leads you to think that the anion is causing an acidosis. No, it doesn't. We're just trying to account for an acid in the system that we cannot see. Does that make sense?
Mhm.
Like ethanol level. We can't monitor it all the time. And it doesn't matter if you're a drinker. If you're a drinker, you can have an alcohol level of 200 or you're not acidosis because you can tolerate drinking. You give me one beer and I'll be acidotic. You give somebody 5 beers and they'll be fine. But there's no pure way of monitoring it except for the anion gap. Does that make sense now? Lactic acid is the same way. Lactic acid. With regards to alcohol, one last trivia before this lecture is over. Not really lecture. It gives you a high anion gap acidosis. You can have alcohol poisoning, which we see all the time. What's the most dreaded complication of alcohol? Withdrawal. Right? So you can have somebody with acidosis on admission, then it would go on withdrawal. 2 minutes. This is actually useful trivia. You guys go to the bars. When do people go into withdrawal?
2 hours.
48 to 72 hours would be the start, but it can last up to a week. 48 to 72 hours after what? After the last drink? Not exactly. It's after the alcohol level goes to 0. The question now is, when do you know if it gets to 0? So you drink at a bar, you have 3 drinks, and your alcohol level is 90. When does it get to 0? It depends. If you drink a lot, it would subtract. So a normal level in the state of legal level in the state of Illinois is 0.008, which is about 81 nanograms per deciliter. 81. If you're a drinker, you would clear it by 20 to 30 an hour, which means if you are drunk, you cannot drive, because even if you're a drinker, it would take you about 4 hours to clear it out of your system. If you're a non-drinker, you'd clear it by 10 to 15 an hour. So if somebody comes in, they don't drink, they have an alcohol level of 100, it would take them 10 hours for that level to go to 0. And then you count from 0 to 48 hours for that person to go on withdrawal. So what's the best thing to do? Discharge them before they go to withdrawal. That concludes the lecture. Any questions, concerns? Okay. All right. Thank you. Thank you for listening.
Your blood gas.
I'll throw it away.
Hang on before anybody leaves, hang on just a second. Let me stop recording.
I feel like I have a lot to learn.
Why can't I stop recording? Oh, there we go.